I'm Mike Schertz. I'm a board-certified emergency physician with over 20 years experience. I have 20 years experience as the medical director for multiple fire departments as well as an EMS agency. I have 20 years experience running a tactical medical program for a regional SWAT team, and for 18 of those years, I was one of the armed and sworn medics of that team. Prior to that, I have 13 years as an Army Special Forces medic. Despite that though, I don't work at a trauma center. I work at a large community hospital. We see nearly 90,000 patients a year and have 58 beds, but we don't see trauma. We get the occasional walk-in trauma. We get the occasional EMS patient that was mistriaged, but it's easy to descend on that patient with all your resources, stabilize them, and transfer them out. What are you going to do if there's an active violent event in your community and you get 45 casualties in 41 minutes? The hospital's got a surge plan, but this isn't surge capacity. Surge capacity is how do they hospitalize more patients than they're licensed for. This is about throughput. No one is a subject matter expert on this material. No one has done more than one of these events unless they're very unlucky. Over a career in emergency medicine, you may never get 45 casualties in 41 minutes. But if you do, you're going to need a pretty robust plan. We're going to draw on the Department of Defense's Tactical Combat Casualty Care Guidelines as well as the Committee for Tactical Emergency Casualty Care Guidelines to frame both how EMS is going to manage these casualties, which I'll tell you is different than how they manage casualties in a typical day. In these events where EMS is overwhelmed as well, you're going to have aggressive tourniquet application, aggressive needle decompression, minimal or very aggressive airway intervention, no IV access, and no triage. A good percentage of your casualties are going to self-present to your emergency department. They're not going to have any EMS or pre-hospital care. In Christchurch, New Zealand, wounded, uninjured, and bloody casualties all presented in the same vehicle. Everybody was covered with blood. Sorting that out is a nightmare. You need a plan for that. It's easy to say, well, these trauma patients should go to a trauma center, but there's CDC literature that 5 simultaneous trauma patients will overwhelm even the best trauma center. You're getting these casualties whether you want them or not. You're an emergency provider. You work in an emergency department. You know what sick patients look like. You know how to manage them. The issue here is the sheer number you're going to get near simultaneously. You need a plan for that. The medical community is very good about studying an event. We know how many units of blood products you're probably going to need. We know what percentage of your casualties are likely to go to the operating room or have critical care needs. What the medical community is not good about doing is making a list of lessons learned from these events. If the same mistakes happen over and over again in one of these events, that's predictable. Something I learned in Army Special Forces is an adage that all lessons are written in blood. We don't want to relearn these lessons from the blood of our casualties. So to do that, we have to look at these events. We have to see what mistakes were made so we can generate a plan. At the end of this course, you'll have a better understanding of how to manage these kinds of casualties and these numbers of casualties in your emergency department. You'll also have a list of questions to go ask your hospital administration and the people in charge of your ED. They probably have a plan. It doesn't necessarily mean that they know what you're going to learn today. This isn't surge capacity. This is throughput and how to save lives.